in partnership with First Nations, Inuit and Métis communities and organisations. As a Métis woman, Dr. Smylie acknowledges her family teachers in Lodge, and I've had the pleasure of knowing Janet for a number of years as a colleague and have really always admired her courage and her boldness in speaking out on issues around colonisation and racism and the impacts of that on Indigenous health. And so I'm really happy to introduce you today. Kia ora.
Tansy, Kinana Skomatin, thank you very much for the kind introduction. I always start with a picture of the land because then it reminds me to acknowledge the land and the territory and the peoples where I am. We had a beautiful welcome to territory yesterday, but I do want to acknowledge the Tiawa and Gati Toa peoples, and that's a picture of my homeland. Along that road we gather medicines, and if you travel a little further along, there's a historic settlement along the banks of a beautiful river called the Saskatchewan River. It's really humbling to be here. It feels like a bit of a full circle. I came here at the very beginning of my research career and was so impressed by this amazing group of Indigenous people who were sharpening their minds and staying connected to where they were from, with the efforts to look at health information as a tool to do something good for the people. Okay. Just clicking. There we go. As Donna mentioned, I have developed over the past 10 to 12 years a research unit, which is a collective. That's a piece of art that actually was drawn by a lodge sister, Christy Belcourt. She's from my ceremony lodge, a very well-respected Métis artist. And one of the things, at least in Canada, one of the things I'm interested in doing always is raising the bar with respect to nation-based, locally rooted, authentic Indigenous knowledge and practice as it gets applied to health systems and health services, including the information that is produced by us, hopefully with us, but often still about us in contemporary contexts. And one of the challenges I found when I started my health research career, so I've been a family doc for 25 years, and after about 10 years, I did a shift over into public health. And it's one of the challenges, I think, with colonization is an essentialization and a dumbing down, right, of what's very rich and diverse and complex Indigenous knowledge and practice. So what I like about this picture is it shows the complexity, and to me, the complexity of the interrelationships between things. And then the other thing that struck me, because Christy actually came, she was sitting at my kitchen table with our lodge teacher, Maria Campbell, and I came down and she showed me this. And of course I, as a clinician, have spent my career working around maternity and reproductive health. And of course, this looks like a placenta, but it's also the story about the beginning of Mother Earth. And it's also one of our ceremony lodges. So I guess the other thing that's probably important is how you talk about what you do to other people within local Indigenous communities and then internationally. So this idea then, this teaching that I got actually early on in my first year of clinical practice from a grandmother whose picture you'll see in the next slide that I every human infant, then we indeed would be over this failed colonial mission. Okay, good, I'm learning how to drive. So right there in the middle, I guess, because I'm in a hospital now, and again, what we do is we all hold different pieces of a puzzle within my own Cree Métis community. I hold a piece of the puzzle. It's kind of a weirdo one. Like I go back home and people are like, oh, what are you good at? Oh, I'm good at writing research grants, like for like external to Indigenous community funders. Oh, well, that's kind of an interesting skill. Let's, yeah, sing some songs or like do some ceremony or cook some food. So what we have at St. Michael's Hospital, and it's a constant and iterative to one of those grandparents. And there is Jan Longboat, a very respected knowledge keeper, ceremonialist. And I've known her actually since I was a very young clinician. So they know me over time. And Madeline Dion Stout and Carol Terry. And then of course we have a grandfather now, Albert Dumont. Okay. Still figuring out how to draw it. I'll get better and I'll move faster. That helps me too, thanks. Okay, whoa, okay, this is the safest thing to do, or is it frozen now? Yeah, okay, stay there, okay. So here, actually, this was my second funded research project, and you'll notice somewhere on there, Ian Anderson, some people know, but I think, yeah, there's Mihi Ratama. So for many decades now, and actually, I think it's a little bit of a distraction now in Canada. People say, well, what will the indicators be that we should measure like Indigenous health by, and how can we achieve equity if we don't have these indicators? So I was very lucky. So Sue Kringle and Ian Anderson and me, he took pity on me when I was a very junior scientist, and we had a little bit of money from the Canadian Institutes of Health Research. So we kind of did this stock take of Indigenous health measurement systems. But in a okay, a little bit slow, so I am trying to click on the slide, advance to next slide. There we go. Okay, so the next couple of slides, and I'll probably get better at driving this, are just going to drill down on some of these concepts then of colonizing data systems. So we've been thinking about this for a long time, and I've learned so much from working then over the past 20 years with some of the people in this room, other colleagues in Australia. But really, in Canada, I don't know that we've really moved away from some of these problems. So what would be some characteristics of colonizing data systems? Maintain control through involuntary counting and tracking, right? So that's why when I go into research, and then in particularly when I tell people, oh yeah, and I'm interested in counting, and you'll see how we've tried to reframe this, like a lot of times people might be like, well, actually, I liked you when you delivered my baby or tried to fix my broken arm, but I'm not sure this whole research thing sometimes felt like I was trying to sell used encyclopedias. Okay, protect this control by monopolizing ownership and access to measurement systems. So this is where, and again, in Canada, we've had some very strong data leaders who talk about Indigenous data sovereignty now, but we've talked about ownership, control, access, and possession for a long time. So not a surprise, right? Because if data systems and tracking us has been used to harm us, then of course we want to have control. Dictate who and what will be counted. In Canada, we have something called an Indian Act that actually is still living legislation. We still have it. So the government of Canada still tries to define indigeneity. And I'll share a little bit about that. And then one of the things I've been fairly obsessed with, and since I went back and did my MPH and thought about health information systems, and then started trying to say, okay, well, how is this working for First Nations, Inuit, and Métis? Those are Indigenous groups in Canada. Is the purposeful and systematic undercount and discounting to maintain assimilation or maintain unequal distribution of health and social resources. So these things are happening like right now in our political system. And I will speak to that. And then finally, are structured to maintain authority over what is a valid count method or system. Okay, good. I figured out an easy way to drive. Okay, so here's just an example, but we actually don't have to go back historically. This came out maybe about 5 years ago in Canada. Ian Mosby was doing his PhD research. So people may be familiar with residential Ian's research is that there was actually a nutritional experiments done on the children in many of these residential schools. And what's quite concerning about it, it actually was a mix of people. So it was university professors and Health Canada people, our federal health people that were all involved. This happened after the Nuremberg trials, right? So it was after World War II in the 1950s. So it wasn't like internationally, Canada was participating and saying these things weren't acceptable, but they were still depriving Indigenous children in these residential schools of minimal caloric intake and then trying to feed them vitamins and then do experiments to see how that would go. Now, every time there's... Okay, good. So basically, what we run into in that, the next little point was around monopolizing ownership and access. Right? So we can draw data systems. This is still commonly what data systems look like for First Nation, Inuit, and Métis community members, and maybe for other members of Indigenous groups. So basically, you can't access most of the data that is collected about you as an Indigenous person in Canada. And one of the things, so an example that I use, for example, in Canada, we had a maternity experiences survey. So a lot of our national health surveys in Canada are based on a census sample. So I actually helped design the survey. I was sitting on a peak body called Canadian Perinatal Surveillance System at that time. And at that time, we actually had a national Aboriginal health organization. So I supported the liaison between that body and this Indigenous organization. And there was actually a promise that there would be a First Nations, Inuit, and Métis specific chapter written in collaboration with that organization. Instead, that organization got defunded. So that data, those chapters were never written. So very slowly over time, and there's one more paper that I want to come out, and I have to credit my colleague, Dr. Nahaya Dowd, who was doing a postdoctoral fellowship with me. So we have to liberate the data. But, and again, many of you are data people, but in order to get to that data, so from like an Indigenous rights perspective, people might say, well, this is our information. It was collected about us. But in order to access it, you have to write a proposal to one of our like peak research bodies. You have to get a security clearance. You have to go into a research data center of StatsCan. You have to know how to code in SAS, right? So yeah, that would be an example of actually people monopolizing data and preventing community access. Okay, dictate who and what will be counted. So again, I've already made reference to this Indian Act. So Canada has a long and complex colonial history, and we have a series of treaties that were signed with First Nations people starting in the 1880s. At the same time, my people, the Métis people, we lost a war with Canada, civil war, in 1885. After that, my people actually got something called half-breed script. There was half-breed script officers and Indian agents. And so the Indian Act still exists. There's been many amendments, but the Indian Act was a colonial act, and the purpose was to deal with the Indian problem. And there was two approaches then. We'll try to control the Indians, right, and re-educate them in these residential schools, or maybe the people who are post-colonial peoples, like the Métis, they'll just assimilate. So we'll give them this half-breed script. So this is an example then of the a status card. So it's interesting, my own family is a microcosm of the Indian Act. So I'm a half-breed script Métis, right, who can trace my lineage right back to some of our very historic areas. And my partner is a Bill C-31 Indian. And what it means is that her mother lost her status because she married somebody who wasn't under the Indian Act. And actually, she then lost her residency on her reserve. And then all her children after that weren't counted as Indian under the Indian Act, right? Though if her brother had married a white woman, that white woman would have become an Indian. So the Indian Act imposed like patrilineal status based on European systems, even though at least my people are a matrilineal people. But actually what you see then, my sons actually are 6'2" because their biologic father is a 6'1", and I'm their biologic mother, so I have no status. So these actual formulas, these are still in use in Canada. So our politicians say that by 2050 there will be no status Indians, so that's the way of making the Indian problem go away. So again, the other piece that I will speak to and that I'm passionate about is that actually only about 49%, here we go, of the Indigenous population in the country then falls under the Indian Act because it's been working, right? But then, like for the last 20 years, I've been sitting in meetings trying to say, oh, okay, but you know, there's 300,000 Métis, and you know, we have some, we're recognized in the they did, right? Like, that's a very strange system of population health and health service planning. And it's hard to imagine that it would actually be acceptable for any other ethnic group, right? Like if we were looking at other ethnically diverse groups in Canada, that you would just exclude one large group of the population. Okay, so just a couple more slides on some of the challenges, and then I want to provide an example. So again, we're talking about deciding on who we count. So basically these Indian Act definitions flood all the way through our core data sources. And then actually, but in a lot of them, even Indian Act Indians aren't counted. So here we're very far behind where you are in New Zealand and also in Australia. So we're really over-reliant on national surveys. And again, I'll share these slides so people can have a chance to look at them. Structured authority over validity of counts, methods, and systems. So this is the other interesting thing is actually one of my frustrations is it seems that not only are there things happening that seem like to be very problematic from a human rights perspective, there also seems to be a double standard around actual technical methods. Because I'm like, okay, well, if you're going to impose like this system, at least, yeah, do it properly. But this slide I'd like to use, again, you know, we saw the Belcourt photo that just gives us a little bit of that beautiful complexity of creation story, like from Belcourt's Cree Métis perspective. But here, this actually comes from a very famous legal precedent case in Canada called the Delgamuukw decision, where the Gitxsan people took on the government of Canada in a land claim debate. And actually, for the first time in Canadian history, oral history of the land was accepted as just as valid as the book knowledge, right? And I find that quite ironic because Canada is a big country and our landscape, just like yours here, can be unfriendly or tough sometimes, right? So I always say, well, what would happen if I was caught in the middle of northern BC in the winter where the Gitxsan people are? What would I like to have? You know, a whole pile of books or somebody who actually knows how to live on the land. So there is actually some empirical evidence that Indigenous knowledge of the land is quite sophisticated and evidence-based. So here we go, the things that concern me. So the first example I was going to use then of how the government actually is trying to structure authority, but actually isn't using proper technical methods, is an ongoing debate I've been having with Health Canada about correct infant mortality. So twice in my career, Health Canada has publicly released infant mortality rates. They're First Nations infant mortality rates that are significantly too low. One was in this report by Paul Webster in The Lancet. And actually, he got a piece of information from Health Canada that said that the infant mortality rate was 20% higher. And that came right off the Health Canada website. And I knew Paul, and I called him. I said, where did you get that? That's wrong. And I tend to be quite passionate about these wrong numbers. I guess actually maybe that makes me a good scientist. But I have other dedicated colleagues who have been showing consistently that infant mortality rates for First Nations and Inuit are 2 to 4 times higher, so 200 to 400% higher. So anyways, I was arguing once with the assistant deputy minister for Indigenous health in Canada, and he said, well, I guess we're having a scientific disagreement. And I said, okay, well, mine's published in the Lancet, so I guess I'm one up on you. But it's actually a very sad state of affairs. And what happens, and we have to be very cautious as international Indigenous health scholars, is then Canada actually starts looking good, right? Because so there's a big motive. The other thing, and this comes, and this is the example then that I'd like to spend a few minutes just sharing in a little bit more detail, is there appears to be a very significant undercount of Indigenous people living in cities. So you'll see shortly, we've been using a method called respondent-driven sampling. And we're actually finding that the undercount is the size of the population in Southern Ontario cities is 2 to 4 times higher than the census count. So really only 1 out of 5 Indigenous people living in cities is participating in the census. But again, this whole validity thing, it's been an uphill battle, even though I've sat on these peak bodies, and I guess I'm a professor at a fairly credible university, to get uptake on this information. Because of course, and some of you know, like Stats Can produces wonderful health and social statistics, but in the case of Indigenous people, it seems that there's some room for improvement. Okay. So let's just switch over then. So we've kind of done the glass half empty and some of the challenges that I've struggled with. And what I should say is it's incredibly useful and empowering and scientifically relevant then for us to have these kinds of international dialogues. And as I've mentioned, for me to have been able to come as a young wanting to be social epidemiologist to the amazing unit here. But one of our leading First Nations health research ethicists, Dr. Marlene Brandt-Castellano, second Indigenous woman to graduate from the school where I went to medical school. She says, fundamental to the exercise of self-determination is the right of peoples to construct knowledge in accordance with self-determined definitions of what is real and what is valuable. So this is exciting too, and this is a way that we can make health information systems seem like pretty exciting, I think, to our young people, and this is where I get my passion. And a lot of times when I'm speaking to more less specialized audiences, we can say land claims. People think, oh, land claims, those 600 outstanding land claims that still exist. I'm like, no, it's actually about the ideas themselves. So can we imagine data systems then where instead of the community being behind this almost unclimbable wall to get at their data, the community's in the middle, right? And then you have a custodianship, a collective of community partners, right, who interface with the community's health information and ensure that it is fed out into research, policy, and practice. Okay, and then as I mentioned, in Canada, we've been through this 10-year process of truth and reconciliation. And what is good about that is, for me as an Indigenous person who wakes up in the morning, because I want to do something useful and relevant for First Nations, Inuit and Métis people in Canada, I have my marching orders now, right? So there's 7 calls to action in the area of health. And the second one actually is about identifying goals and closing gaps and publishing annual reports. My worry, we had something called the Kelowna Accord before, is that we actually can't do that in Canada because our health information systems are too broken, the gaps are too big. And in fact, if we don't actually start working on some new models, right, and getting rid of this idea that, oh, we'll just rely on this Indian Act, it's actually going to continue to mask and undercount these inequities. Okay, and so how do we deal with this problem then? I have my marching orders. I'm supposed to work in partnership with others to produce these measurable goals and help close gaps. So another big gap, one of the biggest gaps, is this idea of the Indigenous people living in cities. So masking comes out of this study. Just gonna, there's a little bit of things coming up. I don't know, I guess I shouldn't close the Zoom meeting, but okay. So in Canada, the large majority of people now live in cities. I live in the center of Canada, Ontario. It's where Toronto is. People think we think we're the center of the world. I have to tell people I'm still nice, even though I live in Toronto. We're pretty busy. But we have the largest Indigenous population of any province or territory in Canada. We also have the largest population. So over half of Canada's population lives in Ontario. One of the concerning things, and I think you've probably got a fairly urban population here, but in Canada, there's this myth that all Indigenous people live in rural and remote areas. And that the reason why there's these health status disparities is because of lack of access to health and social services. And when we move to the city, we'll be okay, right? But you'll see that isn't true. I guess when I'm speaking in urban audiences, I try to be quite careful because it's not like a competition, right? Like we all have needs, we have different contexts as First Nations, Inuit, and Métis people. But I'll say, you know, if I'm in an urban hospital like this, to me that's even more of a potentially reversible health inequity. There's so many doctors in Toronto that as a physician, it's actually hard to work if you were to move to Toronto and want to practice, and we're licensed. They're trying to control because we have such a density of physicians. Yet you'll see in a minute that Indigenous people have a much lower rate of attachment to a primary care provider. So that's different than in the northern communities where people are living without a physician. So we have these critical data gaps. We're invisible in the health administrative databases. There's no inclusive list. So the census was able to get that good coverage for First Nations on reserve communities because they use household enumeration and you can find the houses, and there's a social network that can tell you where you live. But in cities, people are moving around. Okay, so what we've been doing is this project called Our Health Count. So this is the example. And we've been using respondent-driven sampling to find urban Indigenous people. We've done it in 4 cities, and we're in process in 2. And basically, the whole point, and it might seem very simple, but we're just trying to create a data base because we actually don't have even proper counts of people, let alone what are the health status issues, what are the social determinants of health, and what are some of the other challenges. We use a cross-sectional comprehensive health assessment survey. It's long. It's computer-assisted web interface. Community members carry out the interviews. And then we link to our provincial health databases, which already have a very nice linkage across different information sources, including administrative data. That's the part that makes it longitudinal. We do get permission to follow people over time, but we haven't been adequately funded to do kind of longitudinal primary data collection. We can follow them over time through the health system. Takes lots of partners. As I mentioned, we're taking some of the methods from what's called community-based participatory action research into survey development. We had some really good role models. So there is something called the First Nations Regional Health Survey that already had worked in partnership and got community people very active in the data collection. As I mentioned earlier, for each of the projects, we actually have a legal contract where community people are the custodians of the data. So even today, there was a question, can I share these online? So we already have permission to share the slides. Even though they're publicly available, the information, we still say where we're presenting, and ideally, we actually co-present. And then I'm gonna just share a few words on the respondent-driven sampling because I think we're getting fairly close to time. But it's a form of chain referral sampling. But what we do is we actually can start getting population-based estimates because we ask questions about people's social networks. So then we can start calculating the probabilities of characteristics and predict them. So basically, here would be your classic chain referral. These are the operational details. So we hand out coupons. It's incentive driven, right? So as you give out coupons so that people can recruit people in the next wave, if the people they gave the coupons to come in, then they get a little incentive. And it uses Markov modeling. So this is the part where it explains a little bit about how we get to population-based estimates from like a convenience or snowball sample. So basically, if the seed is in one state, you start calculating the probabilities of whether the recruits will go into the other states. So in this case, and Heckathorn is the guy that kind of started this, there are other modified forms of calculating population-based estimates using chain referral sampling and respondent-driven methods. But in this case, in Heckathorn's paper, was talking about, in the states, of course, they conflate racialized and ethnic groups. But if you have state X, which is a white seed versus state groups would be recruited. Every time the bell rings, it's harder to advance the slides, but it's all good. So anyways, the recruitment, as I mentioned, can be predictable, like you can predict it. If you think about a certain characteristic in states of a certain characteristic, you can actually have these probabilities. And what happens is as you go along the chains, right, the probabilities that the next wave of the chain is going to be a certain state start approaching the population-based probabilities. And when that happens, you get a state called equilibrium, right? So the first Markov theorem is as you do chain referrals, the bias from the seed is gradually going to go away. The second theorem is it's going to go away pretty quickly. So by the time you get 4 to 6 people along the chain, you're starting to reach the natural state. And then if you ask people questions about, you actually want them to know who recruited them. And here you can see from our Health Counts Toronto, these are our recruitment chains. You can see a lot of seeds never take off. You actually want 1 or 2 seeds to predominate. And as you can see, like these are some long recruitment chains. So even intuitively, because I work closely with biostatisticians that have helped develop the method and are continuing to develop the multivariable methods, which are complicated. But intuitively, you could understand, like if we gave out coupons in this room, right, and did a chain, by the time we got 28 people on the chain, then it's unlikely that we've influenced like who got the next coupon. Okay, so I just have a few more minutes, but just to say we've had 4 successful samples. The numbers seem small and the confidence intervals will be wide too, because we have a design effect with RDS, but we're actually addressing a complete vacuum of data. I've talked already about the undercounts. So that was a big finding and a big win for us, right? Because we showed there was 3 to 4 times more Indigenous children in the city of Toronto. We got $12.6 million of new Indigenous specific child development funding within a year of releasing that. But I just want to show you some of the other things that we've released. One of the things we do is we've published 50 fact sheets in the last year. So we're slower to get it up into journals because we release it to the community first in fact sheets. These are all publicly available. Apparently my website's down, but we think it'll be up very soon. But here we can see not only did we undercount the numbers, we actually undercounted the poverty. So the National Household Survey actually said that only 26% of First Nations, Inuit and Métis living in the city of Toronto live below the low income cutoff, but we've shown it's 91%. So that means that the census not only is undercounting us, it's dramatically masking poverty and other social determinants of health. We talked quite a bit about racism. And again, I don't want to rush through the slides too much, but just when we just ask about experiences of racism, of course, we know it's always underreported. 50%, over 50% of Indigenous adults are reporting experiencing racism. And then this other question, 84% believe racism towards Indigenous people is a problem in a city like Toronto. And Toronto is actually viewed as quite a progressive city. And then here we see disparities. And where we can, and again, remember we're working without very much data. So of course we try to be cautious about comparing things from different surveys, but you can see that we have very high rates, and these aren't even age adjusted. Right, so a rate of diabetes, 1 out of 5 adults is diagnosed with diabetes, and then high rates of arthritis, and most of the chronic diseases. And here I mentioned about the primary care. So again, we have close to 3 times the rate of unmet health needs. And then you can see the attachment. And this is really in this place where there's too many family doctors, right? But over 1 out of 3 of the Indigenous adults don't have a regular primary care provider. But we're still seeing people, right? So then that's just inefficiency. So this will help us as we navigate through health funding transitions in our region. And then of course, and we've seen this before. In the 2 other studies, we've had 2 to 6 times the rates of emergency room use. And what we're just in the process of doing, this is all based on the survey data, is linking then to that regional health administrative data, and we expect it'll reflect that. And then I think this is quite high rates of hospitalization as well, so it'll be interesting for us to be able to follow that up. And then just to end on a positive note, the other thing is it actually shows a lot of strengths. So the first thing is, it's quite amazing that our community does these surveys. They take off. They're some of the largest and fastest respondent-driven samples ever. Respondent-driven samples are based on social networks. So that's where I get really excited about the method, because it shows that we do have very strong social networks as Indigenous people living in these Southern Ontario cities. And we do have a strong sense of ourselves and sense of identity. We do have strong language retention and desire to pass it on to our children. We participate in traditional ceremonies, and actually we would like to have more access to participation in traditional ceremonies. About half of us use traditional medicines. We feel a strong sense of connection to the land. So with that, I will finish up and see if there's any time for questions. Thank you. Questions, if there's any
online questions. We've got this. Does anyone feel like catching? This is the new mic that we've got.
It looks cool. It looks like you could be on a game show.
It. like up the room at people, but I kind of feel a little bit unsure about it.
You might. I might have gifts for questions. Yeah.
Thank you, Janet. Richard Edwards from the Department of Public Health. I just wonder, what's the sort of reaction of Health Canada to all this wonderful work you're doing? Are things improving in terms of the sort of mainstream data collection and recognition of the sort of data that you're...
So it's complex because we have several stakeholders at the federal level, right? So the jurisdiction for health services actually just shifted from Health Canada over to a new thing called Indigenous Services. And then our minister went over to Treasury Board, and now she's one of the ones that just got ejected from Cabinet. But basically the players would be Health Canada, Public Health Agency of Canada, Stats Canada, and Indigenous Services Canada, right? So I would say that and like right now, Public Health Agency of Canada kind of funds my chair, and they're all like helping and working with me. But I do so do you know, for Public Health Agency of Canada, the Chief Medical Officer of Health for the country told me there wasn't a single Indigenous person dedicated, no, a single person, Indigenous or not, dedicated to an Indigenous file, right? Because they're too busy with the opioid crisis, right? But like Indigenous people are holding quite a lot of that opioid burden, but because of the lack of identifiers, we're invisible. So I would say at Stats Canada, there is some early interest. So there was interest in terms of actually looking at respondent-driven sample for 2021. I have a pretty small team with like one full-time data analyst compared to Stats Can. So I think that's the problem. I actually think there's quite a lot of resistance to actually accepting this as the truth. I think the truth will probably lay somewhere in between. So the studies that we're doing now, we're actually asking permission, right, to link to the census, because I didn't feel comfortable. StatsCan was like, bring your data sets over, right? I'm like, wait a minute, 80% of people didn't do the census. I'm not sure that they would have given me permission. So I felt like I needed the individual level consent. So the first piece is I just think we're really under capacity. It's been really hard to retain over time good epidemiologists. I published on infant mortality, for example, with a really good epidemiologist, Jennifer Pennick, and she had to take her name off the article, right? When we were actually doing the little debating around correct infant mortality rates. And then she left. First Nations Inuit Health Branch, which was the branch of Indigenous Health Services at Health Canada. I think Jane Philpott was a really good ally, and over at Treasury Board, she was working with other Indigenous communities as well. We had a national working group with many of those players, because once you want to get at vital registration, infant mortality, you have to bring in the vital registrars as well at the provinces. And then Health Canada disbanded it because they said, well, we're just going to work on at the regions. So I do think that there's few people within the people that are running Indigenous services that actually have formal training in population health. And that's why I'm trying to talk frankly about these things. I think we actually need to just tell people we need new models. We can't keep doing this. I've had the opportunity to travel to, so the fallback really is let's just link the Indian registry to our regional administrative databases and maybe fund a couple of people to do a survey. But I guess, is any politician really going to get elected? Because on a platform where there's actually 50% more Indigenous people, right? In the country, which actually by these estimates, I hate modeling, right? Because again, it's just, but yeah, not all of these people in the cities are actually registered as First Nations Reserve. So basically, I think that's why it's actually quite useful for me to be able to do this travel. I'm speaking next week in Rotorua, and I'm on a panel that Health Canada has invited me to speak on. So yeah, I'm just, and I'm trying to get research funding, in applications in process. So this is federally funded research. But yeah, I think it's, I have to think of people working in those other positions. Basically we're going to have to have quite an investment. So my current strategy is to actually try to train 100 First Nations, Inuit, and Métis people at a graduate level. And, that's part of the reason I'm doing this international travel, because I think you've done a wonderful job here. And then that next generation can work in all those different places and address it.
Thank you very much. And it was a very inspiring talk. My name's Philippa and I'm going to the conference too. So hopefully I'll get a chance to talk to you there. We've just had a really interesting thing in New Zealand with Stats New Zealand under the last government followed Australia and went for a fully computerised census, and we've had an appalling response rate, which I don't know if you've caught up with, where there's rumours around town it could be 72%, 78%. It's and clearly people who don't have such easy access to computers are probably the people who are going to be falling off being counted at all. I'd be interested in your comments on that, because at the moment I think they're doing this crisis imputation about, how would these people have actually fallen out? But in a sense that you're showing there's a great diversity, and that's not going to be picked up by imputation, I don't know.
Yeah, so we've been kind of working in the online participation. We also, in 2011, they actually dropped our long form census, and now it's back in 2016, right? But so that we had no ethnicity question. They put farming implementation and stuff, or farming stuff in the short form, but they didn't ask about indigeneity. I was kind of grumpy about that. So I think that the imputation is going to be very problematic, because I agree with you that there'll be a bias, a participation bias around like the internet-based. So that would be where even a method like doing a small RDSs are labor-intensive, right? But I'm sure you have strong social networks of Maori, right? Like, so to even do small area like RDSs, just to have something that you can compare to and ask people, did you do it or not? We know when we've introduced, people within Stats could maybe advise you or help you. I could try to link to some of those colleagues because when I was on National Statistics Council, we would hear about like what the participation rates were for online only. And you're right, they were about in the 70s. And we were very concerned that, there would be differential access for Indigenous people as well. While I was there also, we were just looking at getting rid of the census altogether and just using administrative data sets. So I think that's where we did a little bit of lit review, right, as we were trying to frame the population article, because I think this is a global issue, right, as we move towards. So I think people who are socially excluded, if we move towards administrative data sets, right, if we move towards online things, they're going to be underrepresented. And then because most of the time in health, we're still looking at deficit-based rates, right, we're actually then also going to mask inequities.
Hello, my name is Clara Spinell, and I'm doing a PhD on housing first.
Yeah.
So you're aware, so the intervention to look at homelessness. And many of the studies in the papers have come from Canada.
Yeah.
And the claims are that, they're effective for Indigenous populations. But from your talk, I'm taking that really that's very poorly, the methodologies then and the actual population then is very poorly counted and identified.
Yeah, so I gotta be like, some of my colleagues have been involved in housing first. Of course, in principle, we think it's really important. But yeah, so the first thing is all homeless people are gonna be underrepresented, like in administrative data sets and census. But actually, we're finding consistently rates of homelessness that are quite high. So in Toronto, actually, it was 1 out of 4 of the adults was functionally homeless or vulnerably housed. Then Toronto Public Health recently has kind of done an audit, to try to ask about ethnicity. So for people who are out there using homeless shelters, not the population proportion of Indigenous people who are homeless. But actually, I think Raglan even participated in that. And of course, whether you're identified as Indigenous or not depends on who's asking, what the context is, and how they're asking, right? And so that's why this community-based survey method like really works quite well. And we actually have a community validity factor now around indigeneity. There's heterogeneity, so we have to train people to not have, you know, whatever kind of internalized biases. The other thing is, I don't know if you've seen the work that Jessie Thistle has published on Indigenous specific like definition of homelessness, but it's probably worth having a look. So I'm kind of on that a bit in the periphery, kind of supporting Jessie to translate that into clinical practice guidelines. And I'm in a little scientific discussion with a colleague of mine, Kevin Putty, who's writing some national guidelines, right? But we have been working using a ceremonial method actually to come up with some region-specific homelessness guidelines. So this notion that, you know, Indigenous specific homelessness has distinct roots and distinct solutions. There'll be some crossover, but we need to look at it in that way. And it's actually, as I mentioned, my clinical work with inner city health associates, but yeah, it's good. We just got a new medical director, because for a long time every year I'd stand up and say, well, I think we need some Indigenous specific initiatives and stuff. And it was seen as just a vulnerable population within a vulnerable population. But even that's a problematic word, isn't it?
Thank you.
So for that, I think we've filled in the time, and just want to thank Jen again for sharing really generously and around some of the challenges and how histories and both the methods and sort of imposition of knowledge systems carry through into what we do today. I think it's a learning for us as well, but ending with some really hopeful, but also, you know, hopeful statistics around strong, connected Indigenous communities. Just a little hope to thank you, and thanks everyone.
And sorry for all the beeping. The network fell out and we kept losing Zoom, so it's a bit of a nightmare.
That's what the network normally does. 12:27. Just come back. So the whole thing is,